Hello everybody, welcome back to the Stat Dose podcast. We're here doing another turbo dose. Today we're doing upper GI bleeds. Friends of the podcast will be aware that we've already done this, so there's a much larger version for the stat medical topics if you'd like to look at that, but this is just going to be a shorter version just to condense some of that information to enable you to succeed in sim and hopefully succeed in practice.
Upper GI bleeds are hopefully sort of labelled in their name really, but they're technically from it's any bleed from the GI tract except the colon. So the colon being your sort of lower gastrointestinal bleeds, which of course is almost a different patient in and of itself really. And they actually do have quite a high mortality rate. So these patients can bleed very briskly, very promptly. And you've got mortalities of in and around 10% for some of these patients, so they're not to be messed around with. Thinking about the causes of an upper GI bleed, Matt, what do you think in terms of sort of most common?
Most common causes are peptic ulcers, followed secondly by varices, either of the esophagus or the stomach, often secondary to portal hypertension. So just be aware in those patients who often have alcohol excess or those with chronic liver disease. Less common causes though, so anything that's causing inflammation in the same area, so esophagitis or gastritis, just makes the tissues a bit more friable, a bit more likely to bleed. Malignancies, again, in those areas, not a common initial presenting complaint, but as the tumour progresses, they can bleed quite heavily. And malarious tests, where you get to look there sort of cracks in the stomach lining, normally after excessive vomiting.
There are some rare causes, including vascular malformations and AV fistulas, but we don't tend to see those too often.
So as you were saying that, Matt, I was then thinking about how to connect those to sort of underlying risk factors. Definitely use of alcohol. We always talk about NSAID use. Increasing age and chronic kidney disease are almost risk factors that we can almost say for pretty much every disease, and any cause or risk factor that gives you that portal hypertension syndrome. How do they present these patients? I mean, hopefully we would see some bleeding of the upper GI.
So hematemesis, bright red, very striking vomit, often projectile if it's secondary to a variceal bleed. So if it's esophageal or a gastric variceal that's popped, they can be very dramatic.
And I think it's worth noting there, isn't it, Matt, that projectile is something that I hear so much in my practice from people when they say that they've been projectile vomiting. But I think the correlation between what we are looking for in terms of projectile vomiting and what people consider to be projectile vomiting are two separate things. And so actually projectile vomiting for individuals, for patients, is often just a term that is used for some bad episodes of vomiting. And it doesn't necessarily mean the high pressure, sudden onset, distance launched vomit that we're actually looking for.
Coffee ground vomits is a very classic report. Again, it's very similar, as you say there. They're often sort of misdiagnosed or confused. I'm sure you get it a lot on doing sort of one triage and things. I mean, I always try and like to look at the vomit myself. Well, like to is the wrong phrase, but it's always good to look at the vomit if you can. And they should look like proper coffee grounds, very sort of grainy, very black. That's a true coffee ground vomit. Melena, again, very common. Melena doesn't mean any black stool, only dark stool. It's got to be a proper black, very tarry, very offensive smelling stool. They're difficult to flush. You often have to use lots of bleach and things to get rid of them. That's essentially just due to a bleed from the upper GI tract and where the blood gets partially digested, giving that dark colour. Pain is an interesting one. So some patients present with pain. Pain's often a cardinal feature if they've got a gastritis or something like that. But a lot of patients can present without pain. And if it's there, it just suggests a bit of inflammation. So it might be good to give that patient a PPI or alongside some analgesia. If there's no pain present, it doesn't exclude an upper GI bleed. And then finally, the big red flag feature really is a syncope or sort of pre-syncopal sensation associated with any of these symptoms, essentially suggesting that the patient is losing significant blood volumes and is going into a degree of shock. This obviously carries a poor prognostic indication, and if you see that in practice, it's somebody that you want to be giving some blood to reasonably rapidly. The
assessment and management principles, of course, sort of follow in and we would always recommend adopting an ABCD approach to these sort of patients. When you're doing your A to E approach from an airway and breathing perspective, hopefully there's not going to be anything significant to mitigate. The only times I can remember that really are in those esophageal varices patients, where actually they can be so obtunded that they can actually lose their airway, and that's a really, really sick patient. And clearly you would be adopting all of your suction manual airway maneuvers, getting solid airway access and escalating that up to anaesthetics, etc. But thinking about your A to E moving forward, these patients need oxygen, they need cannulation, venous access, 2 cannulas preferable, large bore cannulas again preferable, and ideally we want to start replacing blood with blood as soon as possible if this patient is looking shocked, and not giving too much crystalloid and aiding in that dilutional coagulopathy issue that we see when we're replacing blood with crystalloids with essentially salty water. It's about considering early access and early activation of that major hemorrhage protocol, isn't it? And how that's going to actually be extremely beneficial, because these patients need things quite quickly, and all of those activations, those protocol activations, getting the products to you at the bedside actually takes a lot of time, doesn't it? And so you really need to think about that. Is this looking like a picture that's going to go downhill quite quickly?
So moving on to blood tests that we need to take. Obviously you want to get a full blood count, looking for the hemoglobin, and also the platelet count, which you're going to use up with acute bleeds. Coagulation, again, is important to get a baseline, make sure there isn't a coagulopathy going on. As we've suggested before, a lot of these patients may have a degree of liver failure, so their coagulation might be a little bit off. Obviously, cross matches, so if you're giving these patients blood transfusions, you're going to want to know what their blood group is, just to inform future transfusions. Liver function tests, obviously, we've already mentioned liver, but important to get a baseline liver function there. Use&Es, so the key with use&E is if you have a raised urea, it suggests that you've had what we call a protein meal, where essentially you're bleeding into your upper GI tract. Your body's breaking down what is essentially protein from the red blood cells, and that gives you a disproportionately raised urea to creatinine level. And then a bone profile, again,
can get hypocalcemia secondary to massive transfusion.
What do you think about PPIs, Matt? I know this is a bit of a sort of topical, controversial issue.
Yeah, I mean, they go in and out of fashion, like lots of medicines do. I mean, I tend to give them if there's pain, as I mentioned before. If there's epigastric pain, it suggests there's a good degree of inflammation going on. A PPI there might be beneficial in A, reducing the pain, but B, also reducing the degree of bleeding. I mean, ultimately, it's the risk sort of benefit ratio. The evidence is limited. Some gastroenterologists are really keen on you giving a PPI. Others think it's a waste of time. So I think, consider the risk benefit ratio to your individual patient. From my perspective, if you've got somebody who's having a significant upper GI bleed, and obviously you've started all the other treatment, I think giving a PPI, if it causes little harm and may cause some benefit, go for it.
So another common practice that was around for a few years was the use of tranexamic acid in upper GI bleeds, as we've seen it being used in trauma and in postpartum hemorrhage. However, recently this has come into question with the release of the HALT-IT trial, which no longer recommends standard use of tranexamic acid for upper GI bleeds and gastrointestinal bleeds.
So terlipressin is useful. It constricts the splanchnic blood vessels, so reduces bleeding only in portal hypertension though. So we only use it for our variceal bleeds. We don't use it for all upper GI bleeds. And otherwise, the key medical intervention, I suppose, is actually antibiotics, and it kind of changed my practice a couple of years ago when I was looking into this. The majority of patients, if they don't die from their acute bleed, die from sepsis several days later. Because you're bleeding into your abdomen, blood's a very good culture for infection, essentially. And so a significant proportion of these patients die from sepsis rather than anything else. So it's important actually to get IV antibiotics on board early. As ever, we use Tazocin, like I think everybody does in the world at the moment. So antibiotics early can reduce mortality and they can reduce rebleeding, certainly in cirrhotic patients. But the mainstay of sort of interventional management is an endoscopy. Endoscopies are both diagnostic and interventional, which is great for the patient. So the operator can visualise a bleeding point. They might be able to clip certain lesions. If it's sort of an ulcer or something like that, they can use band ligation, where you inject things into varices, so something like fibrin or adrenaline, and these just prevent the bleeding points from bleeding, essentially. So have a chat with your gastroenterologist of the day and get them on the bleeding list if you're concerned.
So that's just a quick run through of upper GI bleeding. We've talked about the definition causes and how this will present. We've talked about some assessment and your management principles, predominantly looking at your primary survey, getting blood with blood replacement as soon as possible, and therefore requiring some good access, good oxygenation, and your standard sort of A to E approach. Talked about some of the bloods that are important, and consideration of management principles to include, on top of blood products and oxygen, IV PPIs, terlipressin antibiotics, and consideration of escalation to endoscopy from there. And so hopefully that's beneficial for you guys.